Thanks, Susie. That made me feel really old. There we are. I hope you all enjoyed your lunch and you're not too sleepy. So what I'm going to talk about for the next few minutes is a bit of drug development. So this is what it is. I'm also going to talk about some additional indications as well as neuropathic pain if I have time. So, I think you're probably all aware of the opioid crisis. So over 500,000 Americans have died in the past 20 years due to opioid overdose. Be that through overprescription of opioid medicines, things like oxycodone, or through illicit use of things like heroin and fentanyl. So it's pretty obvious that more and better opioids are needed. Now, some think we're a small drug company and we talk to potential investors all the time, and they always ask the same question. Why do you want opioids? They're dangerous. They're all the same, aren't they? And we have to say, no, they're not. The pharmacology can be quite different. And it's quite different because there are different targets, as I'm sure you know, for these receptors. Sorry, for these agents. So 3 classical receptors here. So we have on the right-hand side here, the green guy, that's a kappa opioid receptor. You can see here. So we're not particularly interested in this, although there is a product on the market now, a selective kappa agonist for treating itch. The orange guy in the middle, the mu opioid receptor, as I'm sure you know, is excellent for giving acute pain relief, but it's also a problem because it causes euphoria, which is probably the reason why people become addicted. It also, of course, kills people in respiratory depression in overdose. The delta opioid receptor, which is our target for this candidate compound PN6047, is remarkable in that activating it has shown through a number of different agonists that it causes a good effect on chronic pain relief without having any marked acute pain, acute analgesic activity. Now, our compound is very highly delta opioid selective. So there's some breadth data here from our colleagues in the University of Bristol. And you can see here, so this is looking at activation with PN6047 in human transfects of the delta, kappa, and mu opioid receptors. And you can see here a good effect of the drug on the delta receptor without anything remarkable happening with the 2 other receptors. And looking at these data and some others, it's fair to say that 6047 is more than 100,000-fold selective for the delta versus the mu opioid receptor, and about 7,000-fold selective for delta versus kappa. So we've got a pretty decent window to work with. Now, 6047 is also G protein biased. And here's some data. I hope you can see this. The things are quite small. So this is looking at GI alpha transfects in vitro and looking at increasing concentrations of a number of different delta agonists. I hope you can see this. So there's something called SNC80, which is kind of the archetypal delta agonist. It's been around for a long time, and you'll see that a few times as we go through the slides. DADL is a peptide agonist. Here's our compound 6047, and there's another synthetic agent, ARM390. Now, we haven't found anything, and nor has anybody else, that really is a partial agonist in terms of GI protein signaling. But that's very different when it comes to looking at some other transduction systems, and the one that we've concentrated on and other people have is arrestin signaling. And you can see there's a big difference here, because even looking at, here we have transfect of the arrestin-3 protein coupled with GFP, and you can see already that there's some partial agonism here. And our compound is about a 60% partial agonist in relation to the control SNC80 compound. And that's even more marked when you look at arrestin-2. And so again, PN6047 is about a 50% partial agonist compared with the control agent. If you do the stats on this, and a lot of people don't do the stats for bias properly, but this is done by Professor Eamon Kelly, our friend and collaborator in the University of Bristol, and you can see here that there is a marked selectivity for G protein signaling compared with both arrestin-3 and arrestin-2. So here's PN6047. The dotted line here shows the line of equality, if you want. So SNC80 has no difference in terms of its signaling between G protein and arrestin 3 or G protein and arrestin 2, whereas 6047 and this peptide DADL show marked GI protein selectivity. Now, why do we care about arrestin? Does it really matter whether it's recruited or not? And again, I apologize, it's a bit small, but on this cartoon, what you can see is this shows an agonist. Let's say this is a delta opioid G protein coupled receptor. Once it's activated by an agonist, it gets phosphorylated by a kinase, of course, and then in the phosphorylated form, it can recruit arrestins. And the arrestin complex is then able to be internalized, so it's taken into clathrin-coated pits, and from there its fate can either be destruction in lysosomes or it can be recycled. So arrestins, we think, are very important in terms of controlling DOR trafficking. Now, if you actually measure internalization, the removal of the receptors away from the cell surface, these are the kind of data that you see. So this is measuring, this is using the old DiscoverX bimolecular complementation assay, and so you can see here this is measuring internalization in vitro, and here's SNC80, pretty good at causing internalization. PN6047 and DADL, much less effective. And here are some data, and again, I apologize, it's much better on the screen than up here. These are some in vivo internalization data, and these are generated by our colleague and collaborator, Amina Pradhan, in Washington University in St. Louis. So what these show, these are animals, they've been treated with either PN6047 or with SNC80 down here. And what we see are hippocampal slices expressing the delta opioid receptor labeled with GFP. Now, if I'd been clever and shown you this at a decent size, you could see that the vast majority of the receptors, the labeled receptors after SNC80 treatment, are in the cytosol. So there's marked internalization. It's not a great picture, I'm sorry, but what you can see is there's not much difference, if any, between vehicle treatment and PN6047 treatment in terms of in vivo internalization. So we're pretty sure that this reflects the inability of our compound to cause removal of the receptors away from the cell membrane. And some years ago, our collaborator, Amina, produced a few papers, and her take-home message was basically this. So in vivo, delta opioid receptor internalization controls the behavioral effects of delta agonists. So what she was saying was that agonists retain their full analgesic effect when the receptors are on the cell surface. But when they're internalized, you get complete desensitization. And we've, admittedly, this is not in vivo, these are some in vitro data where we challenge cells transfected with the human delta opioid receptor with high concentrations of, for a prolonged period of time, 48 hours, with either SNC80 or with the agonist DADL, or with PN6047. This was actually measuring GI function by looking at cyclic AMP reduction following forskolin accumulation. And what you can see here, what you can not see there, what you can see here is that after exposing the cells to SNC80 or DADL, there's no longer any GI-mediated effect. Whereas after exposure to PN6047, there's still a significant agonist-related G protein effect. So it's resistant to desensitization. Whether this is directly due to arrestin interaction, we really don't know, but the correlation is there. Now, why do we care about delta opioid receptors and what's their role? Why do we think they might be good candidates for treating neuropathic pain? Well, these are some data that were produced, or a very pretty picture from, God, I keep doing that, a very pretty picture from Greg Shearer in Stanford from some years ago. And what Greg showed was that despite the fact we know that the delta receptors are highly expressed in the central nervous system and in the peripheral nervous system, they're particularly highly expressed in these sensory nerve endings in the skin. So the Ruffini endings, Merkel's discs, Meissner's capsules, all of these are the terminals of fast-conducting myelinated axons innervating the skin. There are also some, not as highly expressed, but some delta receptors along with mu receptors in the C fibers, the poorly myelinated, slower conducting pain fibers. Now, the interpretation of this, the function of these receptors is really to control mechanoreception. So touch and pressure are really under the control, we think, of these delta receptors. Now, what we think is that this means that allodynia is a good therapeutic target. Allodynia is the situation experienced by a lot of neuropathic pain patients where even very light touch to the skin becomes horrendously painful. And that can make even simple things like getting dressed in the morning extremely difficult. So that's why we think that this is a good target. So does it actually do anything in neuropathic pain? Now, these are some data that Susie Hage produced in PESH some years ago. And this is in the rodent sciatic nerve ligation model of neuropathic pain. And it's measuring hyperalgesia, in this case in the foot. You can see here this anti-allodynic effect, which I'll tell you about in a minute. I do keep pressing the wrong button. So what we see here is that this hyperalgesia, allodynia, is very well blocked by a dose of 1 mg per kilogram oral PN6047. And that effect persists for up to and over 2 hours. Now, importantly, we found that this anti-allodynic effect, this blockade of hyperalgesia, seems to be a peripheral effect. So I haven't got the data to show you, but this effect is completely blocked by naloxone methiodide, a pan-opioid receptor antagonist that doesn't get into the brain. It's also consistent with a bunch of constitutive delta opioid knockout experiments that have been done. Importantly, this anti-allodynic effect doesn't appear to show marked tolerance. Again, some data from PESH from some years ago, and you can see that here, whoopsie daisy, I am really stupid today. So here we can see that I'm getting stupider as the days go by. So you can see here that there's no difference in the hyperalgesic effect of PN6047 after treating for up to 16 days. This is very markedly different from standard opioids, where you see marked tolerance of analgesic effects, even within a few hours of treatment. And in the clinic, this of course means that you have to keep increasing the dose with the increased risk of side effects as treatment goes on. Just a little side movement here, because I think these data are quite interesting. Now, I'm sure you know that there aren't very many drugs that are any good at treating neuropathic pain in the clinic. But some drugs that have at least a partial effect in some patients are the antidepressant drugs, things like amitriptyline and duloxetine. And these data were produced some years ago. These data were produced some years ago, and they show that treating, these are the SNL model of neuropathic pain. So this is measuring pore withdrawal in the foot of the poor old rat poked with von Frey hairs. And you can see that, Jesus Christ, you can see here that this is the pore withdrawal, which is very greatly reduced in the SNL model, and this is pretty effectively reversed by a dose of duloxetine. Now, if you try and do the same thing in animals where the delta opioid receptors have been knocked out, you can see that there's no effect. So the existing neuropathic pain therapy in this case appears to be mediated by delta opioid receptors, and this gives us some confidence that a direct activation of the delta receptors will give at least the same sort of effect in neuropathic pain as the antidepressants, and hopefully a bit better. Now, something that's important, as soon as the O word, the opioid word, arrives, people tend to think, well, these are useless drugs because they cause addiction. So we've been very keen on looking at the potential abuse liability of this compound. Now, our collaborator, who's very, very sadly passed away, Emily Yudkowitz at the University of Michigan died at the height of their powers at a very young age just a few months ago. And these are some data that Emily produced. And this shows, in this model, rats are trained to self-administer remifentanil, which is a non-selective opioid agonist. So the rats seem to enjoy this. They'll give themselves an intravenous infusion quite often. So here you can see this is the number of infusions that these rats will give themselves. They'll still self-inject a little bit of saline, and this is simply because rats are pretty inquisitive and they like to nose poke to get any sort of injection. A little bit surprisingly, this archetypal delta agonist SNC80 seems to be, shall we say, anthropomorphically enjoyed a bit by the rats because they will inject more than they injected saline. But when you look at SNC80, there really is no difference between the rats self-administering this drug and self-administering saline. So we don't think, at least from this paradigm, that there's a risk of abuse liability. We've also gone on to look at drug discrimination and condition-placed preference paradigms, and again we've seen no effect of PN6047. So we're pretty confident that abuse liability is not an issue. Now, you may have thought, well, if this is such a good target, why on earth haven't proper big pharmaceutical companies developed agonists that have got onto the market? And I think at least part of the reason is because some of the early compounds, things like SNC80 and things like the AstraZeneca compound AZD2327, these did produce convulsions in animals preclinically. This is by no means the case for other delta agonists that have been produced, and it's by no means the case for this drug, PN6047. So we've tried pretty hard to produce seizures in animals. We've been to very high toxicological doses and have still seen no seizures. But we went on to see if there was any proconvulsant potential. And again, these are data produced by Emily Yudkowitz a few months ago. So what Emily was doing, she was measuring EEG in rats. And so the top trace shows the effect of the very well-known convulsant agent pentylene tetrazole. So here's the injection of 56 mg per kg PTZ, and you can see there's marked EEG activity. When you look at what happens with, and this is 100 mg per kilogram of PN6047, so this is 100-fold or probably greater more than the, if you like, the active therapeutic dose, and you can see there's no EEG stimulation. So taking both into account, we're pretty clear that convulsion is not a worry for this particular drug. So if you're talking about overall safety, so we've looked, of course, in the regulatory toxicology studies in rats and dogs, and we haven't seen any significant adverse effects. And I think more importantly, of course, we haven't seen any significant adverse effects in the phase 1 studies, either CVS, central nervous system or respiratory system. So both phase 1 ascending, single ascending dose and multiple ascending dose studies have shown no significant adverse effects. So I think these data and the preclinical efficacy data do support the clinical efficacy testing of 6047 in neuropathic pain patients. But specifically those subtype, that subgroup of neuropathic patients who suffer from allodynia and hyperalgesia. Now, if I've got time, have I got a few minutes?
The counter is just there.
Oh, I've got loads of time. Yeah, keep on rabbiting away. Okay. So, our collaborators in the US have looked at a couple of different indications. And so this one is, I am an idiot. This one is opioid-induced hyperalgesia. So, I'm not sure if you know about this kind of paradoxical increase in pain sensitivity that some people experience on repeated opioid administration. It's very obviously, it's easy to demonstrate this in a preclinical setting, of course. Now, it's also, this increase in pain sensitivity is also an element of opioid withdrawal syndrome, because of course, people who are trying to get away from their addiction think, well, why should I stop taking this analgesic drug? It's only going to make things worse, which of course it doesn't. It's just the opposite. Now, what Amina Pradhan in Washington University has done is to look at a model which she developed, and this is treating, in this case, these are mice, treating with 20 mg per kilogram of morphine sulfate twice a day for 3 days, and then increasing the dose to 40 mg per kg on day 4, then leaving it for 24 hours and looking at what happens in the animals in terms of hyperalgesia. So these data here show peripheral opioid-induced hyperalgesia. This is in the foot. So this is poking a poor old animal with von Frey hairs again. And I think you can see pretty clearly that in this situation on day 5, so they've developed a marked hyperalgesia. So the mechanical threshold has dropped significantly. And this is very well reversed by increasing doses of PN6047. And there's a single dose here of SNC80, the archetypal delta agonist. It does the same. Now, you can have a look at a different sort of hyperalgesia, and that is cephalic. And this is, some people would say this is kind of a model of headache. I'm not totally convinced, but nevertheless, it's looking at a different anatomical location. So this is poking the poor old animal round its orbit with the von Frey hairs, and as you can see again, there's a marked hyperalgesia. There's a marked hyperalgesia. So here on day 5, we see a big fall in the mechanical threshold, and this is totally reversed in this case by doses of PN6047. So we think that this is probably an interesting indication for the drug. Now something else, I don't want to make this sound like snake oil. It's not something, this drug doesn't fix everything. But I think that migraine is another potential indication. So I'm sure you know that, that nitroglycerin, or glyceryl trinitrate, as well as being an explosive, it's a vasodilator, and it's used in the treatment of angina. But in migraineurs, people who suffer from migraine, it will precipitate a migraine attack. It even produces headaches in non-migraineurs. So you can see here, this is treatment. It's a model that Amina developed. So it's giving rodents a dose, quite a large dose actually, 10 mg per kilogram of glyceryl trinitrate. And you can see that measuring the mechanical threshold, this drops remarkably after 10 days, representing a hyperalgesia. Now if you, I wouldn't have shown you this, would I, if PN6047 didn't do anything. But I think you can see that here we've got, this is treating animals just with saline, treating intact, unmessed with animals with PN6047 at 3 mg per kg. And here we have animals measuring again mechanical threshold after treatment with nitroprusside. And so here you can see this big drop, this big hyperalgesia is very significantly reversed by PN6047. Now, some migraineurs, I'm sure you know, develop an aura. So prior to seeing headache, they'll get this visual disturbance. And this visual disturbance, people are pretty sure is due to this thing of cortical spreading depression. So we're talking about waves of depolarization which cross the cortex, and this is followed by relatively rapid hyper-sensitization. So you can see here, again, this is the model that we just saw, looking at nitroglycerin-induced migraine-like model. And so you can see that the vehicle, this is measuring CSD events electrophysiologically. SNC80 reduces the number of CSD events, as does PN6047. So again, looking at both the model of aura and the model of migraine headache, we can see a good effect of the agent. So if we ever get round to getting the money to do it, we'd like to test it in migraine as well. Now, poor old migraineurs, they should never be treated actually with opioids, although some physicians will still think it's a jolly good idea to treat their headaches with opioids. It's not a good idea because prolonged opioid treatment, as I said before, will sensitize the poor old cells to headache. Now, what this shows, this is measuring mechanical threshold in animals that have been treated with a very low dose of nitroglycerin. If you remember, the previous dose was 10 mg per kilogram. This is going down to 0.01 mg per kilogram, but combining it with 10 mg per kilogram of morphine sulfate for 11 days. And on the 12th day, you can see that there's this developed hyperalgesia measuring mechanical threshold, and that is completely reversed by treatment with PN6047. So this potentiation of migraine-like pain with nitroglycerin is blocked with the drug. So I think, again, this is a potential for treating migraine. Now, I said earlier that the effect in terms of neuropathic pain blockade was peripheral. And yet we do see some effects of this drug, which must be, I guess, mediated by the CNS. And so in agreement with the effects of other agonists, we see an antidepressant-like effect of PN6047. So this is not great. This is the good old tail suspension test. So it's not a great depression model, but it's not a bad test of some antidepressant drugs. And we see a good, significant effect in the tail suspension test and also in the forced swim test. So maybe a bit of antidepression would be a good idea for patients who are suffering from long-term neuropathic pain. We also see some anxiolytic-like activity. And again, these are some data from Amina Pradhan in Washington. And so this is looking at the performance of animals on the elevated plus maze. And I won't go through it in detail, but I think you can see that, whoops-a-daisy. I think you can see here that on the closed arms, no change with the drugs. With the center area, no change. But in the anxiolytic, if you like, open arms, you can see a good reversal by these delta opioid agonists. So maybe antidepressant and anxiolytic activities may be a good idea to combine with neuropathic pain treatment. So what can I say to sum it up? I think we've got a missed opportunity by Big Pharma. So delta opioid development isn't a dead duck, and I think it's worth following. Our particular agent, PN6047, seems to be safe and well tolerated, and so it's ready to be treated for efficacy testing certainly in neuropathic pain, but maybe in opioid-induced hyperalgesia and maybe migraine. So ready for efficacy trials, and if we get the money to do it, we'll be starting these over the next few months. I just want to thank some people. So thank you to Bengt, who started off our little company some years ago. Bengt's in the audience. The lovely Emily Yudkovitz, who, as I say, very sadly passed away a few months ago. Amina Pradhan. Our colleagues in the University of Bristol, Eamon Kelly and Alex Conivere, and of course Susie, who's in the audience today. Thank you for the invitation, Susie. And thank you for the National Institute of Drug Abuse for funding some of these studies. We'll never ever see that funding again as non-Americans. Thank you, Mr. Trump. And we've got some funding from the European Innovation Council. And thank you for listening, particularly after your lunch.